With that, we are thankful to have Dr. Noor Dabul. Dr. Dabul graduated medical school in 2010 from the University of Tishreen. She went on to complete her internal medicine residency at Conemaugh Memorial Hospital in 2016. She then completed her hematology oncology fellowship at the Allegheny Health Network in 2019. She has since served as an assistant professor in hematology oncology here at WVU. She has been a great teacher to our residents and fellows, and we are grateful to have her here today. Please join me in welcoming Dr. Dabul.
Thank you so much for the nice introduction. I'm sharing my screen now. Please let me know if you all can see it well. Can you see my screen well?
Yes.
Good. Okay, thank you. So thank you so much for having me today. Actually, it's a very good timing. March is the awareness month for colon cancer. So it's very good to talk about colon cancer now and to increase more awareness for more screening that really saves lives. And not only decrease mortality, but also improve quality of life with less ostomy or ileostomy and better overall survival. So thank you so much for being here. We will talk in general about colon cancer and more updates from our GI ASCO in 2022. It's very hard to put all what I wanted to say in one topic, especially with a limited time. I'll try to be summarizing most of the hot topics there, like a ctDNA or immunotherapy. But if you have more questions or you need more details, even if that 10 minutes or 15 minutes for questions are not enough, feel free to email me. So let's start the presentation. And colorectal cancer is the fourth most common diagnosed cancer in the States and the second leading cause of death in men and third in women. The incidence has been decreasing recently because of better screening. However, the incidence has been increasing for patients younger than 50. We're seeing more and more younger patients in the clinic. And when I say younger than 50, as young as 25 years old with no significant family history. The mortality from colorectal cancer decreases significantly from 1990 to 2007 and currently is down of almost 50% from the peak mortality, most likely because we're catching it more early and we're having much better treatment modalities these days. Now, screening has been to catch more asymptomatic patients early enough, so we're treating more early stages disease than before, yet we're still not on target for screening. So I'm happy we're talking in March now. It doesn't have to be March and the awareness month. Please, as much as we can, to educate our patients about importance of screening. So what are the risk factors of colorectal cancer? Of course, some inheritance ones and some are modifying risk factors. For example, inflammatory bowel disease, Crohn and ulcerative colitis, smoking, taking more red meat, alcohol. Now, diabetes itself, you can consider it a risk factor. Insulin increases the risk, however, metformin decreasing it, mainly in women. Of course, low activity level, metabolic syndrome, or obesity by itself. Now, taking more fish or dairy products is good. We will talk a little bit about aspirin and non-steroidal anti-inflammatory drug. Yes, it may decrease the risk for certain population, and it improves survival for the ones who already have colorectal cancer and they have the BIK3CA mutation. The inherited colorectal cancer, multiple syndromes. I'm just going to talk about the two most common ones. Lynch syndrome, hereditary non-polyposis colorectal cancer, the risk is up almost 4%. Familial adenomatous polyposis is the second most common as well. For Lynch syndrome, we have to check for immunohistochemistry MMR protein, mismatch repair protein, and that is kind of equivalent but different from the MSI status. So we always start with the more fast, which is MMR protein. We can actually run it here in our lab at WVU. If some is deficient, for example, if MLH1 is deficient, then you have to confirm with MSI status. That is a sent out test. I don't want you to mix between them. We use the terminology of PMMR, which is a proficient mismatch repair, or MSS for stable cancers. So screening for colorectal cancer, talking how important it is. So For average risk patients, which is the most common, we start screening at 45-year-old, and you can be done with the screening at 75 years old. As long as life expectancy is more than 10 years. Like if you have a patient with a 70 years old and metastatic cancer, that the life expectancy is 1 year, you don't really have to continue screening for them. As long as life expectancy is more than 10 years, like a 70-year-old who has a prostate cancer, he may still have a 10-year life expectancy. You still can go ahead and have the screening done for them. Now they leave it for patients 75 to 85 as optional. You still can do it if you want to. What screening, what we should do? The best and most common and eldest is the colonoscopy that you do every 10 years. And again, this is for average risk patients. You still can do the FIT, which is the fecal test, once a year. Or you can do the multi-target DNA test, Cologuard, 1 to 3 years. Now, the DNA test is more sensitive than the FIT test. However, it has a lot of false positives. So we have to be careful who to recommend it for. And also we can do the CT colonography as well, once every 5 years. Now, we always have to explain to them if they chose not to have it done, any of the positive tests have to have a stat colonoscopy ordered for them. We still offer colonoscopy, but if they chose not to do it, then you can offer these ones. Now, I did not mention here, but you still can do, for example, sigmoidoscopy with FIT test or sigmoidoscopy with the DNA test. So you still can do that. It's not as colonoscopy, but it's test biopsy. So for patients who are high, not a standard risk for colorectal cancer, there are some risk and some will not.
How was the dog with Dr. Bell
It
yesterday?
was good. She's great.
She is. So I didn't see this yet. Are you? I'm not in
Getting
CPR.
logged in.
Okay.
Can someone mute all the microphones?
See the
And a personal history of inflammatory bowel,
9:30 and the 11.
a history of abdominal radiation. One of these risk factors will influence how often you would screen your patient and when you will start. However, other risk factors, which we already know about, like obesity, diabetes, smoking, alcohol, we know it increases the risk, so they are not standard risk. However, there is not yet a recommendation to screen these patients more often. So I'm showing here the risk of colon cancer when patients has family history. If no family history, you can see here, I don't know if you can see my pointers, is the lowest risk. If you have first degree relative, it's a little bit higher. If you have a first degree relatives, but less than 45-year-old, it's much higher. The highest risk if you have multiple family members with colon cancer. Now, just like a comment here, they include also high-risk polyps. It doesn't have to be invasive cancer. So what is the enhanced screening for those ones who have Crohn's disease, for example, or they have a family history? You start at 40 or 10 years earlier than the first degree relative diagnosed with cancer. If a patient has a father or a brother with a colon cancer at the age of 35, then you start the screening at 25. Or 40 if it comes earlier, and you repeat screening every 5 years instead of every 10 years. Now, if they refuse, in this population, colonoscopy is better. But if they refuse to do colonoscopy every 5 years, you still can do the FIT test or the DNA test. Now, we talk a lot about vitamin D and colorectal cancer, a lot of data there that even patients will ask you, should I take more vitamin D? And some trials are still going on to answer this question. But what I can tell you, vitamin D deficiency may contribute to the incidence, and vitamin D supplement may decrease the risk if you prevent that deficiency period. Low vitamin D level has increased mortality from colorectal cancer. Now, if you give supplement, Vitamin D and calcium has no effect or has no decreasing of the recurrence of the cancer yet with all the trial published. Only individuals who have a certain receptor allele may benefit from supplementation. Now, none of the studies has proved that vitamin D supplementation improve outcome. We are now having Solaris trial here at WVU that studied a high dose vitamin D to see the outcome for patients who already have colorectal cancer. But bottom line, what I need you to remember, it's reasonable to check vitamin D level for all patients with colon cancer and give vitamin D if it is deficient. Now, to answer the question of high dose vitamin D for those who doesn't have it deficient, it's still ongoing. How about aspirin? They also ask about aspirin, like they will tell you, oh, what do you think? Should I take aspirin to decrease my risk of getting colon cancer? And actually, yes, some trials showed aspirin, non-steroidal anti-inflammatory drug, may decrease the risk of getting colon cancer. However, you always have to weigh it against the risk of bleeding. So especially, we have much better screening now, modalities and catching earlier colon cancer. Now, if you have a patient with already diagnosed colon cancer, we have to check for PIK3CA. Giving aspirin to these patients should it should improve mortality. This is published in the New England Journal of Medicine. For all comers, if you see here, there is no difference for either disease-specific mortality or overall mortality when you give aspirin. However, if it's a mutant PIK3CA, yes, there was a difference in mortality. So please give aspirin for those patients who have the mutation. Again, this is for the one who already have diagnosed colorectal cancer. Staging. We stage colon cancer regular TNM staging. What I need you to know here, and I included the NCCN staging for TNM colon cancer. T stage is very important for colon cancer. It has a very important prognostic value over N stage or lymph node positivity, which is not for the rest of the cancers. For example, pancreatic cancer. Also, the T stage is all that deep, how many layers is involved rather than how big it is. So you can remember any lymph node positive is a stage 3 per definition. That's one thing. T4 is a stage 2 if it's N negative. And you can look up here, the 5-year survival is less for stage 2B comparing to stage 3A, which is not common. Stage 2B has a T4 T stage N0. How about, however, stage 3A has a T3 or T2 N1. So that will confirm what I was just saying about the importance of T stage in prognosis for colon cancer and rectal cancer as well. So for patients who have a local disease, surgery is the best next option. There are multiple trials to show that you can do an open or laparoscopic surgery. The only difference is how many days they stay in the hospital after, but outcome is similar. For stage 1 patients or MSI high, stage 2, no adjuvant treatment is needed. So that's a straightforward, easy question. Stage 1 colon cancer, MSI high, stage 2, surgery is enough. You just keep them on surveillance. Don't need to do really CT scan surveillance, but just physical exam, and they come to you as needed. You can order scans. You have to be doing colonoscopy at least a year after surgery, and then depending on what you find, like if there is a high-risk polyp, you decide the subsequent colonoscopies. So stage 1, stage 2 high MSI, you don't need any adjuvant. How about stage 2 that are MMR proficient or stage 3 colon cancer? Yes, disease-free survival showed the difference if you give them adjuvant treatment, more significant for stage 3 comparing to stage 2 in multiple trials until we were able to define those from stage 2 who have higher risk and they will benefit more from adjuvant treatment. So the 5-year survival, if you give adjuvant for stage 3, and I will tell you one thing, for stage 3 colon cancer, that's the most common question I get in a clinic. If the patient come to get adjuvant treatment, they will ask me, what is the benefit? Why would I take 3 to 6 months of adjuvant chemo if you tell me I'm cancer-free, the surgery was good with negative margin, and there's no more cancer cells there? And that's what you can answer them. The 5-year disease-free survival when you give adjuvant treatment for stage 3 improves from 49% to 63%. So it's a proven that you decrease the chances of cancer recurrence when you give adjuvant treatment for stage 3. Now we're doing better job in defining high risk versus low risk, how much chemo to give them to decrease long-term side effects for these patients. So just a quick thing about Oncotype and Coloprint and all these multi-gene assays to tell you the risk of having cancer coming back. All of them can inform about the risk, but not yet proven to affect clinically outcome. So even if the patient requested to do it, you can tell them it may tell you the risk of recurrence, but yet it did not show clinical benefit to treat those who have high risk depending on these test results. Similar to breast cancer, for example. Breast cancer, when you do Oncotype for them, you can clearly tell them you will benefit from adjuvant chemo, but not the same with colon cancer. Yes, they show that they can tell you the risk, but not yet clinically correlated benefit. So adjuvant treatment goes as far away as 1990. They started 5-FU levamisole actually, and then they improved over years until we have the 5-FU leucovorin regimen that we use now in 2002. So that answer was questioned since 2002, that single agent 5-FU with leucovorin show survival benefit for stage 2 and 3 colon cancer. Now, multiple other questions. Is capecitabine, which is Xeloda, an oral form, fluoropyrimidine, like similar to 5-FU leucovorin, is non-inferior, is as good as 5-FU leucovorin? Because to ask your patient to get a pump IV chemo for 6 months is not easy. The other question is adding oxaliplatin will add more benefit. Third question, adding irinotecan may add more benefit. How about biological agent, anti-EGFR or VEGF inhibitor? 3 months or 6 months, and sulfoxyri, so even give more enhanced chemo as an adjuvant. I will not go through into details with all these questions for the sake of time. I just put there in bold the name of the trials which address these questions. I'll just tell you a summary, what you need to remember about adjuvant treatment to give more time for metastatic disease. So the X-ACT trial compared 5-FU to oral Xeloda showed it's non-inferior. So yes, you can offer your patient oral pill instead of 5-FU. Just to tell you though, although they have similar efficacy, they have a little bit different side effect profile, although they have the same mechanism of action. When you take it orally, you have more GI side effects, and also you have more skin side effects like hand-foot syndrome. When you take it 5-FU leucovorin IV, you have more bone marrow suppression. Mosaic trial, which we all remember, addressed the question about adding oxaliplatin to 5-FU as an adjuvant, and it's a positive trial. It did show statistically significant survival benefit of adding oxaliplatin to 5-FU single agent for stage 2 and stage 3. There is multiple analysis that came later, even up to 8 years later, to tell who is the most that benefit from adding oxaliplatin. And to tell you a summary, younger patient or those who have lymph node positive stage 3. So for stage 2 or elderly patient, you're okay not to give oxaliplatin and to give only single agent capecitabine or 5-FU. So the biggest question and a very, very good data called IDEA trial to answer, is it 3 months is as good as 6 months to decrease amount of chemo and long-term side effects, most important neuropathy, tingling numbness that could be permanent. And this trial included multiple countries and it has a really good analysis. And what I can tell you, they were able to define those who we consider high risk and who we tell them, please get 6 months of treatment. Patients who have T4, and we previously mentioned how important the T stage to tell prognosis, and patient who has N2 or like T4 or N2. You need either of them. They benefit more from 6 months comparing to 3 months. And that's mainly for the FOLFOX arm. For KBOX arm, it's less prominent, so you can still offer T3 or N1 patients to have 3 months of KBOX instead of 6 months. And that showed benefit in a neuropathy outcome as well. Now, more updated data in GI ASCO 2022, more data is leaning forward to decrease amount of oxaliplatin. So they studied patients 6 months and they see, okay, if we stopped oxaliplatin earlier, would it be inferior? Actually, the answer is yes. Stopping oxali too early is inferior. However, if you give 50% or more, you still may be good to hold oxaliplatin and continue single agent 5-FU or capecitabine to finish that 6-month time. And again, the benefit is more for those who have T4 or N2 disease. So the conclusion from the IDEA trial is 6 months is superior for comparing to 3 months for FOLFOX arm and those who have T4 and N2 disease. So elderly patient, 75 or 65, because there is a different cutoff between data. Would they benefit? Is it worth it to give them adjuvant treatment? And the answer is yes. Giving elderly patient adjuvant chemo is safe and is beneficial. However, even if you have a stage 3, you may consider giving a single agent, 5-FU or Xeloda, not add oxaliplatin, and that you can give them more quality of life. So neoadjuvant treatment, neoadjuvant chemotherapy for colon cancer patient. And it's not as well established as patients who have rectal cancer because of a lot of difference between colon and rectal cancer anatomy-wise, lymph node drainage-wise, and more layers that protect the rectum for local recurrence. However, giving neoadjuvant chemotherapy before taking patient to surgery will not add to their survival. However, it may make surgical outcome better for those who have very large tumor, T4 or more, or that is more adherent to nearby organs. For example, if you have a patient who had a large tumor that invading into the wall of the bladder or the vagina, yes, they will benefit as per Foxtrot trial to give it 3 cycles of FOLFOX chemotherapy and then go to surgery. You continue 9 cycles after. That finishes exactly the same recommendation of 6-month treatment. So you're not giving more chemo. You're splitting the chemo 3 chemos or 3 cycles before surgery, and then you finish the rest after surgery. And that showed benefit in surgical outcome, but not overall survival benefit. So if the surgeon reach out to you that the mass is large, I'm worried I cannot give a negative margin, then it's a good idea to give the patient 3 cycles of FOLFOX. So just in summary, what I need you to remember for adjuvant, which means stage 2 and stage 3 disease, we define patient for low risk and high risk. For stage 2 and only MSS, we don't need to give adjuvant for MSI anyway. What is the high risk features for them? One is T4, as we mentioned multiple times before, poorly differentiated histology, LVI, PNI, if they present with bowel obstruction, perforation, or if they get a positive margin. And if they get through the surgery with less than 12 lymph nodes resected. Any of these ones is considered the high risk stage 2. And for those, you would recommend to get treatment, not observation. Now, NCCN will tell you observation for lower risk versus single agent versus FOLFOX versus KBOX. But most of the data showed not a lot of benefit of getting oxali for these patients category. For stage 3, what is the low risk and high risk as per IDEA trial? T4, N2 is considered high risk. We prefer 6 months of FOLFOX. You're okay to give 3 months of KBOX for T1 to 3 or N1 disease. That's a diagram just to make it a little bit easier for adjuvant treatment, who and what, how much to give adjuvant treatment for. Just a summary of all what we were talking about. So again, to answer the questions for these trials, 5-FU versus capecitabine, non-inferior, you can give capecitabine. Adding oxaliplatin, yes, it showed survival benefit mainly for stage 3 younger patient. Adding irinotecan, no, although irinotecan showed a good response, survival benefit for patient with metastatic disease, not as an adjuvant. And again, I put the names of the trial that had this result. Adding biological agent as an adjuvant, like anti-EGFR, cetuximab, or panitumumab, or Avastin, did not show benefit in adjuvant setting, similar to metastatic setting. And 3 versus 6, we discussed IDEA trial. Fulfoxiri, actually, we have an ongoing clinical trial to see fulfoxiri as an adjuvant if it's better than Fulfox. But we will see the outcome of this. For now, adjuvant is either Fulfox, Kbox, or single agent 5-FU Xeloda. That's all what you need to remember about adjuvant for stage 2 and stage 3 colon cancer, which is so much different from metastatic colon cancer. So talking about metastatic colon cancer, it's very important here to know the biology, to know the molecular. And sometimes you really cannot even decide the treatment if you don't know MSI, if you don't know BRAF, HER2, KRAS, NRAS, and you still need to know, is it left-sided colon cancer, right-sided colon cancer, because the treatment outcome are both different. It will make you think like it's not really one disease you're dealing with. It's multiple diseases under the name of colon cancer. And this diagram will tell you how much difference we have in the mutations between right side colon cancer and left side colon cancer. For example, more MSI, BRAF, and larger tumor are on the right side comparing to left side. More RAS mutation and HER2 on the left side. Now, what percentage of colon cancer has HER2 and BRAF? And what is the worst mutation ever to have in colon cancer? And do right side has an overall worse survival comparing to left side? And the answer is yes. Right side has an overall worse survival comparing to left side. And the worst mutation to have in colon cancer is a BRAF mutation. Almost it's in 10%. And the one that's studied is V600E mutation. HER2 is almost 5%. Both of them has targetable treatment, so they have a little bit better survival comparing to previously, but yet they are considered bad. Now, how about KRAS? Yes, it's still bad. Not good to have it. The only good one that we like to have it is if you have a deficient MMR, they really have better survival. But KRAS, NRAS, HER2, and BRAF are all considered bad mutation to have. So metastatic colon cancer, we divide them in, are they metastatic to oligo organ, like only liver, only lung, or multiple organs? And these liver lesions or lung lesions, are they resectable like oligometastatic 1 or 2 lesion at the same lobe that you can resect them or not? Reason we do that in colon cancer, even if you have a stage 4 disease, you still can get definitive treatment, which is sometimes curable, different from other cancers. Like, for example, pancreatic cancer. If you have a stage 4, you don't talk surgery anymore. They don't benefit from getting Whipple or surgical resection of the primary if they have a proven metastatic disease. But in colon and rectal cancer, they respond very well to treatment, and they do have some benefit of getting definitive treatment if they present as a resectable metastatic disease, or if you convert them from non-resectable to resectable. Like if they present with a 20 liver lesion, you give chemo, and now you ended up with 2 or 1 liver lesion, you still can discuss with them definitive treatment. So if they present with a resectable metastatic colon cancer, like a colon cancer with 1 liver lesion or colon cancer with 1 lung lesion, 50 to 60% develop mets, 90% happen in the liver, and that is unresectable. Now, 20 to 30% present with metastatic disease, doesn't happen after you give them treatment. Definitely, it has more poor prognosis comparing to non-metastatic disease. What other poor prognosis? If you have extrahepatic disease like a bone disease or peritoneal carcinomatosis, if you have more than 3 tumors in the liver, the disease-free survival, for example, if patient presented with a stage 2 or 3, you give them adjuvant, and then in less than a year, they have a metastatic disease. That is considered worse prognosis for those people who have metastatic disease. This is what is different in colon cancer. Cure is still positive. Overall survival is 71% at 5 years for those who can resect the metastatic site, which is much better than other cancers. Now, if, for example, you have a patient who had 1 or 2 liver lesions and the surgeon tell you, I cannot have a liver surgery because of a heart disease, then you can offer liver-directed therapy, TACE or Y90, or radiation treatment. That's still considered definitive treatment as well. The most benefit is you can get your patient some chemo-free time. Even if this treatment was not a curative, at least you can give them some time to be off chemotherapy and enjoy better quality of life. So please reevaluate patient every time when you have a metastatic colorectal cancer, you repeat scans, and you see that they are responding well to treatment, reevaluate for definitive treatment. This is one of the trials that studied patients who presented with resectable metastatic disease, like oligomet to liver. Should we take them to surgery right away for the primary and the liver mets, or should we give chemo first and then take them to surgery? And actually, the outcome of this study showed both categories have similar surgical outcomes. So you're not decreasing chances of surgery by giving chemo ahead of time. They are not losing a chance of it. Now, initial chemo improved patient selection to get hepatic resection. So it will tell you who are the ones who will progress and will not benefit from surgery, which most of us prefer to give a couple of months of chemo before surgery. However, the post-operative outcome is highly worse if you give chemo. Definitely, they will take more time to recover. They will have more bleeding risk. They will take more time to recover in the liver surgery as well. So don't give 6 months of chemo and then take them. If you have a good response at month 2, take them as early as you can. So that's just a bottom line to give chemo before for those who presented already with metastatic resectable colon cancer. What chemo to give these categories? You still can do FOLFOX, you can do FOLFIRI. The biggest question, should we add anti-EGFR or Avastin or not? Be careful with adding Avastin, because if they're presented already with resectable ones, so you can take them to surgery from get-going, give chemo only or chemo with anti-EGFR is better, because Avastin, anyway, you have to hold it 6 weeks before or after surgery, and it will have more risk of bleeding and delayed wound healing. So it may not be one of the options we would choose if they present already with metastatic resectable cancers. Peritoneal carcinomatosis up to 17%. They have it 2%. It's the only site of metastatic disease, because most common site of metastatic disease is liver. And there are multiple studies to check debulking surgery if it's the only site of MET in these 2% category. HIPEC showed some benefit if you're sure this is the only site of disease. There is no overall survival benefit, but disease-free survival benefit. So if you have a patient who presented with metastatic colorectal cancer, but multiple mets, not resectable from the get-going, still, you can convert them to be resectable in up to 10% of patients. You have to choose a good regimen to help. The best yet is FOLFOXIRI to convert patient from non-resectable metastatic to resectable metastatic disease. Adding cetuximab and panitumumab increase response rate and R0 resection, but not overall survival. And it's proven in multiple clinical trials. Again, I put the names for them here. I can't present all of them for the sake of time. Now, BEV improve response rate for those who had an oxali regimen and they have a RAS mutation. So if you have a KRAS mutation, you cannot give anti-EGFR, but Avastin showed benefit if you give it for this category of patient. Now, don't give more than 6 months before you take them to surgery if they convert it to, because that increases liver toxicity. And if you have a metastatic patient with non-resectable, they have deficient MMR or MSI high, please consider giving immunotherapy, either Nivo alone or Nivo-Ipi, that showed yet the best response rate comparing to any previous chemo study that has been done. And I'll mention that trial in a little bit. So For those who presented with unresectable metastatic disease, yes, you still can use all the regimens we talked about before. Please add biological agent for those who qualify. And when I say qualify, we'll talk more into details, but what I need you to remember, right side colon cancer, you don't give anti-EGFR, you only can give Avastin. KRAS and RAS mutation, you also cannot give anti-EGFR, it has to be Avastin. And for those who present with non-resectable metastatic disease, if you give FOLFOX or KBOX, there is a strategy called the stop and go strategy. You give it 3 months, 6 cycles of chemo, you re-evaluate. If they have a very good response, you can hold oxaliplatin and continue only 5-FU biological agent Avastin or cetuximab. And whenever disease progress, you can put oxali back. So you're kind of saving oxali for later. What is the benefit? Although there is no survival benefit of doing this stop and go strategy, it saves a lot of patients from permanent neuropathy. Oxaliplatin-induced neuropathy can be as bad as preventing patients from walking. They may be on a wheelchair because of it. It's very important to catch it early. It's very important to try to prevent it, because even when you stop chemo, it may get worse more, and then it may improve a little bit, but a lot of them have irreversible neuropathy. So stop and go strategy, it's studied in 2 ways. You can stop oxali only on continue 5-FU biological agent, or you can stop everything. And the outcome is better if you stop only oxali, continue 5-FU maintenance treatment with or without biological agent. Maintenance therapy, if you finish the 12 cycles for FOLFOX, FOLFOXIRI, or FOLFIRI as a first-line treatment for those patients, yes, all these trials prove that giving maintenance treatment is beneficial. And maintenance treatment can be a single agent 5-FU, Xeloda, with or without Avastin, Bev, or biological agent cetuximab or panitumumab. Now, again, if you remember the first picture we put, we need to know the biological. One of the most common mutations is a RAS mutation. It's almost 40% in colorectal cancer. We talked that it showed a worse prognosis if you have it. The most common one is in exon 12 and exon 13. G12D, G12C are the 2 common ones. The test has to be done. If you don't have enough tissue in the primary, you can do it on the med site or the opposite. In GI ASCO, actually, 2022, earlier this year, it showed a very good trial that studied KRAS G12C mutation. We already have a sotorasib that's approved medication for this mutation for non-small cell lung cancer. And this trial, it showed some benefit for the another targetable one, which is adagrasib chemo for those patients who have a KRAS G12C as a second line or more. We do actually, it'll be open soon, the clinical trial here for this certain mutation to answer this question. Give this with or without chemo will have a better survival for patients who have a KRAS G12C mutation. BRAF, it's almost 5 to 10%. It has the worst prognosis. BRAF is similar to RAS mutation. It will indicate no benefit from using anti-EGFR, cetuximab, or panitumumab without using BRAF inhibitor. So if you get a patient with a BRAF, you cannot give FOLFOX cetuximab, for example, but you can give them BRAF inhibitor and cetuximab at that time, because that, as per Beacon trial, showed survival benefit. There are 3 regimens approved for BRAF mutation currently as a second line or more, but more workup is being done to get it as a first line treatment, not yet FDA approved. HER2 mutation is another targetable mutation, less common comparing to RAS mutation and BRAF mutation. It may indicate resistant to cetuximab, panitumumab, but it's not as good studied as the previous 2 ones. We have also 3 regimens approved to target anti-HER2 mutation as a second line or more, not a first line treatment yet. And they are kind of comparable, but some of them you can still give if you have a failure on a previous anti-HER2 treatment. Again, for the sake of time, I'm not going too much into details about each one of them. Anti-EGFR, multiple trials showed survival benefit from using anti-EGFR, cetuximab, or panitumumab as a single agent or with chemotherapy. The most common ones is the PRIME trial for the panitumumab that showed survival benefit. The most important info I need you to remember, don't give it for right side ones. They did worse actually comparing to left side ones. So if you compare the numbers, for example, here, if you give cetuximab and that was for like right side cancer, it showed that survival benefit is much worse. However, it did much better if you give it to left side colon cancer. So when you compare it to Avastin, it showed a little bit better response when you give it to left side, but both are comparable actually. So for left side, you can still offer either of them, but for the right side, it's not an option to give anti-EGFR. So again, longer survival for the right side showed with Avastin comparing to, and it's a huge difference, 13 months versus almost 30 months. So please make sure you know the side and the KRAS, NRAS, BRAF status before you decide to give the patient cetuximab or panitumumab. MSI status, it's very important to determine if they have MSI high or not for immunotherapy, number one, and to determine if is it a germline MSI high, a germline mutation that is Lynch syndrome, that is inherited, has a risk for other cancers, and you still have to check family member, or it's a somatic mutation that doesn't have inheritance problem, yet you still can offer them immunotherapy, but at least it's not the germline that you have to screen your patients for other cancers and screen his family member. How you prove it? You can send a germline test like Invitae, for example. There's also some hints. For example, if you have an MLH1 and PMS2 in an elderly patient, you kind of know this is not the inheritance type. This is most likely a somatic acquired mutation. You have to have a hypermethylation studied. You have to have a BRAF mutation studied as well. But if, for example, only MSH2 or only MSH6, you think it could be really Lynch syndrome. So there is some hints to tell you, but at the end of the day, you still have to send the test and confirm if it is somatic mutation or a germline mutation. So immunotherapy in colon cancer, it's approved. We talked a little bit about neoadjuvant to make it more surgery for those who present with metastatic disease. And for metastatic disease, it's not yet approved as an adjuvant after surgery. So multiple trials checked for immunotherapy in metastatic colorectal cancer. All of them or most of them are checking for those who have MSI high or deficient MMR. The Checkmate 142 checked for Nivo-Epi for previously untreated MSI high metastatic colorectal cancer. If you have Nivo-Epi comparing to Nivo, you have a better response rate. They respond much better. Toxicity is higher, like immunotoxicity, for example, dermatitis or colitis or pneumonitis will be higher. However, it's still better response rate. So you can choose your patient who doesn't have any, like, for example, history of autoimmune disease. The other two trials that checked pembrolizumab in MMR deficient, you have the Keynote 016 that included all solid tumor, not only colon cancer. And that gave a different dosing from the Keynote 177 that target only colorectal cancer. So if you open NCCN guideline, it will give you two different dosing for Pembro for those colon cancer patients who have deficient MMR. Although both are approved, we more likely like to follow the Keynote 177 because it was a dedicated one for colon cancer. But the Keynote 016 included all comers, like if you have a deficient MMR, lung cancer, or pancreatic cancer or so, you can still include them. Now, the NICHE trial studied neoadjuvant immunotherapy. And actually, it was an excellent trial, showed almost 100% response rate and 95% major pathological response for those who ended up having surgery. This included patients only with deficient MMR or MSI high, but that will tell you how better option immunotherapy for those patients comparing to chemotherapy. There are trials to study both together, chemo-immuno, which may be good for certain ones who have a large bulk of disease. But for now, at least, I can tell you with all these data, at least the 4 trials we have, immunotherapy is an excellent option for those who have metastatic colorectal cancer and deficient MMR and no contraindication of giving immunotherapy. Second line treatment, multiple options. You have a single agent or doublet. If you use FOLFOX, you can go to FOLFIRI or the opposite. You can add cetuximab, panitumumab. If you progress on anti-EGFR, don't continue it. But if you give FOLFOX Avastin and you progress, you can still do FOLFIRI Avastin. There are also trials for regorafenib, which is corrected trial, TASE 102, which is the recourse trial. Both showed mild survival benefit, but it showed it. So they are both options. They are both oral chemos, not the easiest to be tolerated. You still can choose any of them. There is no difference if you choose one as a third and the other one as a fourth line. They do have different side effects profile. TASE 102 is more myelosuppression. So if your patient had 3 or 4 chemos before, their bone marrow is not as good. It may not be a good option. Regorafenib has more GI and diarrhea swelling side effects. So you can choose between them depending on the side effects profile. Some nice updates from the GI ASCO 2022. More leaning forward to decrease use of oxaliplatin, again, for the tingling, numbness, and in long-term neuropathy. There is the ReSPECT trial that studied oxaliplatin with BEV only, or like you remove oxaliplatin and give 5-FU BEV for metastatic colorectal cancer, especially in elderly patients, and actually did not, it was a non-inferiority trial, did not show benefit. So you still for elderly can remove that oxaliplatin and continue 5-FU BEV if you want to, depending on this trial. So greater toxicity for oxaliplatin, combination did not prolong disease-free survival. That's why we feel more comfortable to hold off or discontinue oxaliplatin even earlier. You don't have to finish the 12 cycles for these patients. The next update I wanted to tell you about are for those who have neuroendocrine tumor, although we did not mention much about cancer except for adenocarcinoma histology, but neuroendocrine tumor, we used to give poorly differentiated neuroendocrine tumor similar to the lung, like you can remember small cell lung cancer regimen. If you give cis etoposide, like what we did, they also compared irinotecan etoposide, and it's not inferior. So it's a very good option, especially irinotecan is much better tolerated and studied more for GI cancer patients. The other one, you hear a lot about ctDNA, and then you use, even patient will come and ask you about, okay, how about the blood test that to check for my cancer cells? Am I a candidate? Actually, we have multiple studies before that showed correlation with prognosis. In GI ASCO 2022, there is a Galaxy trial that showed actually a very good correlation between positive ctDNA 4 weeks after surgery and poor survival, poor prognosis, and higher risk of cancer recurrence. It also showed if you give them chemo, you decrease that chances. So that answer some, not the whole question, but some of the question. If you get a patient who's very hesitant to get 6 months of chemo for stage 3 cancer, you can help them and offer them ctDNA. If it's positive, you tell them you may be the one that responds well to adjuvant chemo. You will be the one that will benefit most from adjuvant chemo. So it's mainly to tell you who, we already know who to offer adjuvant chemo, but from those who may benefit the most from getting adjuvant chemo, to order ctDNA. There are the 2 ongoing trials to decide about correlation between prognosis and a treatment for those who have a ctDNA positive, and multiple other trials are ongoing for other subset of patients. Doesn't have to be adjuvant for even stage 4 cancer. ctDNA works for circulating tumor DNA in the blood. It's a blood test that it checks for the cancer cells DNA in the blood. It's best if you have it high and went down to almost 0 after surgery, or if you have it high and went down after you give chemotherapy. Most of the trials showed that positive or increasing ctDNA can predict cancer recurrence much earlier than CT scans, which we use usual for screening modality. Again, I told you before, colorectal cancer awareness month is March, so please remember to advise your patients about getting screening. Any questions for me?
So there is a question in the chat. If MLH1 or PMS2 deficiency is sporadic, not germline, is response still good to immunotherapy?
Yes, excellent question. And the answer is yes. Your patient at that point doesn't have inheritance, so they are not at risk for prostate cancer or breast cancer or other cancers. You don't have to screen their family members, but you still can offer them immunotherapy. Yes. Doesn't have to be germline.
Great talk, Noor. You covered a lot of ground today. I know there's a lot of updates going on in the exciting field of colon cancer. Looks like there is another chart there from Dr. Mupamambe asking, have agents targeting HER2 been studied in colon cancer, and how Herceptin can be a game changer in this regard?
Yes, HER2, I can go back to that slide. Definitely, HER2 has been studied as a targetable HER2 mutation for colon cancer. You have trastuzumab, which is Herceptin. It's the oldest, it's the My Pathway trial that showed survival benefit using it second line or more, not the first line. You also can use this, for example, after you progress on HER2. To be frank, their survival and data is not as good, but definitely it's an option. They have a good response rate, but they lose that response in a very short period of time. So the duration if response is not the best. As breast cancer ones, you still have to have an echocardiogram, you still have to be monitoring them for a cardiac toxicity, and you can choose among these three regimens because they have a little bit different side effect profile. But Herceptin is included there in 2 trials, actually, for HER2 mutated colorectal cancer, metastatic only, second line or more. Thank you, Midon. I cannot read the question. Somehow I don't have that chart, so thanks for telling me about it.
Any other questions for Dr. Dabul?
All
Okay,
right. Well, so I was just going to say, thank you, Dr. DeBold, for presenting on that today. We really appreciate it. For everybody, that will conclude today's grand rounds. Thank you for joining us today.
thank you so much for attending. Bye.